let's take a person who has a statin, who is having a CRP of say 2.5, let's say.
Yeah.
So what are the options available with us? So one is standard control your blood pressure, diabetes, obesity, that's one. And control your LDL level back to normal. In the diet, we normally say kadwa and kasela.
Yeah.
That means astringent and bitter food. They are supposed to reduce IL-6 and IL-1 beta, जो कि इसका main pathogenesis है. थर्ड कम्स इज स्टैटिन एंड फोर्थ कम्स इज लो डोज एस्पिरिन. दोनों के बारे में बताइए. लो डोज एस्पिरिन कब चालू करें, उसका क्या इफेक्ट है, और स्टैटिन्स कैसे स्टार्ट करें?
Statin तो much depends upon the individual risk of the patient, whether this is a primary prevention, which means that he does not have confirmed atherosclerosis, and the LDL levels have to be seen. If there is a family history, if the patient has risk factors like hypertension or diabetes or chronic kidney disease or smoking. Smoking is a very, very serious risk factor, which is often not emphasized as much as it should be. And the LDL levels need to be brought down. And if the LDL levels are to target level, depending upon the age and the perceived atherosclerotic risk, at least 50% reduction in the LDL, the dose has to be tailored in such a way. Or for us, it is advisable to go to levels of 70 or less. In those who have had atherosclerotic disease already, no matter whether it is in the coronaries or in the cerebrovascular system or in the peripheral arteries, their target LDL levels are less than 55. So one has to follow that and then adjust the dose of statin accordingly.
Do you think that people...
Yes.
Go ahead.
Carry on. I'll answer the question first. Then.
Do you think that CRP of more than 2 also requires aspirin? You combine both the answers together.
Aspirin and primary prevention, we have had, some setbacks in the recent data. People who do not have evidence of atherosclerotic disease, whether or not aspirin should be given in primary prevention has become questionable now. In fact, a large body of data exists that says that we don't need to give aspirin in primary prevention anymore. But including those who have diabetes, unless the patient has multiple risk factors or has suffered from an atherosclerotic event. If he has suffered from an atherosclerotic event, then yes, aspirin is indicated. If he hasn't suffered from an atherosclerotic event, then usually we don't give aspirin these days. We used to give it to everybody earlier, unless there are other very high risk features in these patients. And in those who have suffered from disease, certainly low dose aspirin therapy is to be administered, and then one can monitor these CRP levels. But the more important than aspirin would be that if there is a specific inflammatory residual risk in somebody, then one of these anti-inflammatory drugs like colchicine has proven to be extremely effective in a very small dose, like 0.5 milligrams once a day or at the most 2 times a day, in terms of reduction in CRP.
So how long we can continue colchicine?
The data that has been published, obviously there is a finite time in the trial, so that was about 2 years' time. But for how long? Well, one doesn't really know, but probably it will have to be a long term, very much like what the statins did. We don't have long-term follow-up. We don't have a 5-year follow-up as yet because this data is absolutely recent, 2019, 2020 on colchicine.